Mine is a very simple topic. I could finish it in 2-3 slides. પણ હવે આટલું બધું ઓર્ગેનાઇઝેશનને કર્યું છે તો 5-10 મિનિટ બોલું થોડું. I am going to talk on the 4 pillars of heart failure management, which we are all aware in day-to-day practice, but there is a point, there is a principle which I want to highlight here. The gamut of the problem or the magnitude of problem in India is very high, equivalent to a pandemic. About 1% of the adult population of our country is affected by heart failure due to one etiology or the other. Compared to Western countries, the mortality in our population is pretty high after heart failure admission. That is because of various factors which we will discuss later. Whatever patients are diagnosed are not even adequately treated. The medicines that are proven to be beneficial are implemented in the range of the adherence to medicines in the range of 25 to 50% only. And as every disease like diabetes and hypertension and CAD, heart failure also appears early in our population. The younger individuals are affected much more. If we see the graph here on this side, this pointer is not showing. The mean survival, we see the spiral here, there is a pretty rapid downward spiral once the patient is diagnosed with heart failure. And first hospitalization, the mean survival is 2.6 years, which gradually reduces down to 1.5 years within the next 2 hospitalizations. We have lots of cancer institutes established everywhere, but if we see, heart failure kills more people than cancer. The pointer would not work here. I have another one. If that's okay. We may try to focus. And not just mortality, but it also has a detrimental effect on the quality of life, the psychological issues. Patients with heart failure suffer with depression, anxiety. They face limitations in the day-to-day activity, social responsibilities. Everything is affected. If we see a local registry of India, only 1/4, as I said previously, 1/4 of the patients were prescribed the ideal drugs or the GDMT, the guideline directed medical therapy, which has 4 pillars, which we will discuss in a while, at the time of hospital discharge. And if you see those curves there, the patients not on GDMT or guideline directed medical therapy had a much higher mortality rate compared to patients on GDMT on optimum doses or target doses. This is again a slide which shows the prescribed medicines. We are very fond of diuretics because they immediately give symptomatic benefit, but actually they don't give any survival benefit. In fact, they are deleterious. They sometimes accelerate the neurohormonal cascade and lead to progression of heart failure. Followed by beta blockers, because we have a lot of CAD patients, it acts as anti-anginal also. We give beta blockers to many patients. And MRAs, the mineralocorticoid receptor antagonist, spironolactone, because they are usually combined with diuretics. Look at the drugs at the top, ARNIs and also the ACE inhibitors and ARBs. They are prescribed in much lesser percentage, and these are the real drugs that do give a lot of significant benefits, but we tend to miss that often enough. Why do we do this? There is an entity which you are all familiar with, known as clinical inertia. My patient is stable. બહુ વાંધો નથી, થોડુંક લેસિક્સ આપ્યું, સારું થઈ ગયું. It's stable છે. I should not, there is no need to change the medicine. Patient બી એમ કે સાહેબ જૂની દવાથી સારું છે, એ જ ચાલુ રહેવા દો ને. કે માઇલ્ડ સિમ્પટમ્સ છે, થોડુંક જ છે સાહેબ, બહુ તકલીફ નથી, વધારે કામ કરું, શ્રમ કરું ત્યારે. We accept all these excuses for not up-titrating or optimizing our therapy to the targeted doses. The stable heart failure actually is, the phrase is a misnomer, because overtly patient સારું દેખાતો હોય, patient may look good from outside, but they always carry a risk of hospitalization or sudden cardiac death. If you see the graph here, the patient would be in a compensated phase of heart failure or asymptomatic phase for a while, and then it waxes and wanes between compensated and decompensated phase many times before the ultimate most severe presentation of instability, that is the missing patient. and that equates to what we say as mortality. So, by treating heart failure, what are we aiming at? Our treatment goals includes both the clinical outcomes like reducing the mortality, reducing the hospitalization, and protecting the kidneys. We are all as clinicians aware that once the patient of heart failure has a creatinine which starts rising from say above 1.5 to in the range, reaches in the range of 2, the average survival after that is hardly 2.5 to 3 years. And we also target the quality of life where we want to make the patients feel better, not just live longer, but feel better and have a meaningful life with regards to functional capacity so that they can carry out their activities of daily living and some productive activities for earning. These are the 4 pillars. I will combine these RNE and ACE inhibitor as, or ARBs as the first pillar. The second pillar is the mineralocorticoid receptor antagonist, spironolactone and eplerenone. The thirds are beta blocker and the 4 is the SGLT2 inhibitor. My endocrine friends, all my friends here, SGLT2 inhibitor primarily is a heart failure molecule and not an anti-diabetic molecule, and we will see why in details later. The first pillar is RNE, which was discussed a little bit in the previous 2 talks by Dr. Rajiv sir and a little bit by Dr. Vishal. It is a combination molecule. We know the product profile, so I am not going into the details of that. But if the patient has been on ACE inhibitor or ARB, it is recommended to have a 36-hour washout period before we can start RNEs. It is a combination of valsartan and sacubitril. Sometimes we face challenges in starting this molecule because the heart failure patients have low blood pressure in the range of 80s or 90s, but even then do try to give an attempt starting at a very low dose of 25 milligram a day, once a day or even twice a day, and then up titrating. If needed, reduce the dose of diuretics, reduce the dose of other vasodilators. Of course, it will carry all the contraindications of ACE inhibitors. We should not be using in renal artery stenosis bilateral and pregnancies. The second is the beta blockers, which is used for more for the anti-adrenergic and anti-arrhythmic effect. The beta blockers commonly used are the vasodilatory ones, bisoprolol, carvedilol. Of course, metoprolol has been used in many trials. We need to start this when the patient is in the compensated phase of heart failure, of course, when the patient is normovolemic and not hypervolemic. The third molecule is the spironolactone, mineralocorticoid receptor antagonistic. It is used more for its anti-fibrotic properties and it also has mortality benefits. Eplerenone would be preferred over spironolactone if the patient has gynecomastia or sexual side effects. And the fourth pillar is the SGLT2 inhibitors, the dapagliflozin or empagliflozin. They act with natriuresis, they lead to volume reduction, and they also have cardiorenal benefits as mentioned in the previous talks. The side effect profile of these drugs, we need to watch out for genital mycotic infections, and it also can sometimes cause normoglycemic ketosis. So we need to watch out for these side effects in these patients. Up titrating the dosages to the target dose is a very important aspect. RNEs we have been using in our clinical practice to up to dosages of 200 milligram twice a day. Beta blockers, we hardly go up to 50 milligram for carvedilol or 200 milligram for metoprolol. Indian patients, people say are low body mass, they don't tolerate higher doses, statin is side effect high. It's not so. If we are diligent in up titrating the dose, we can very well reach our targets, and that will translate into significant benefits. Spironolactone and eplerenone to 50 milligram per day, and dapagliflozin, empagliflozin, fortunately they are recommended in one single dose, 10 milligram daily. Rapid safe up titration. So when the patient is hospitalized or the patient is diagnosed with heart failure, within 2 to 4 weeks we need to get all these therapies on board, so much so that by 8 weeks all these 4 therapies or the 4 pillars should be on board in the targeted dosages. For that we'll need to do blood test frequently in the first 1 or 2 weeks to watch for side effects, and then these can be repeated at 2 monthly intervals. What do we look for? We might want to see, these are special situations. As I said, for low BP, if the patient has a lower heart failure patient has a lower blood pressure, we might prioritize SGLT2 inhibitors and MRAs over RNEs. If the patient has CKD, again use SGLT2 inhibitor, use MRA with caution. Beta blockers, we know the contraindications, And one important thing is that, as I said, in patients with diabetes, SGLT2 inhibitor would be, diabetes with heart failure, SGLT2 inhibitor would be much more preferred to start early. We need to watch out for potassium and creatinine. We need to omit certain other drugs if they are used. As somebody said previously, avoid non-steroidal anti-inflammatory drugs and avoid salts with high potassium content. To improve the adherence, we need to start all these drugs early, simultaneously, and we need to work on the prescription where fixed dose combinations or once a day combinations. If some company can come up with a once a day combination for ARNIs, we have combinations with metoprolol combined with dapagliflozin. So all these mix and match would help. Cost is a problem because these drugs are on polypharmacy, and fortunately for all these 4 drugs, good quality generics are available. So if a patient is not affording, they can definitely seek that. Also, we need to have some heart failure clinic type setup in our hospital where a heart failure nurse would do some teleconsultation, give reminders for improving adherence and compliances. I'll skip this slide because we know these contraindications. All contraindications for ACE inhibitors or ARBs translate to contraindications for ARNIs. But one important point is sometimes we start these heart failure medicine and these ARNIs and the creatinine rises. Up to 30 to 40% rise in creatinine should be acceptable. It usually stabilizes, it comes down later. We need to make sure the patient is not dehydrated. But this translates into much higher clinical benefit compared to the numerical increase in creatinine that we see at the initiation of therapy. With regards to these 2 drugs, essentially they are the same. Dapagliflozin has more robust data with regards to reducing rehospitalizations, whereas empagliflozin has more robust data compared to reducing CV mortality, but you can take them as equal for essentially for heart failure purpose. There are other additional molecules. One of them is vericiguat, which is to be discussed later, and other ancillary therapies for heart failure. But all these 4 pillars, they are class 1 indication as given on that side with a very high level of evidence for all these class of drugs. So mandatorily all patients should be on these 4 drugs. So much so that if you see the drugs, these 4 drugs, at what ejection fraction they are recommended, if you see the last green bar of SGLT2 inhibitors, they would be useful even if the ejection fraction is normal. So heart failure with preserved ejection fraction, one of the drugs can be, to start with, can be SGLT2 inhibitors. Similarly, ARNIs and MRAs, as Dr. Karnik sir was also saying that it was evaluated as an antihypertensive agent, but even in patients with near normal ejection fraction, these 2 drugs would give benefit, delay the progression of heart failure. Beta blockers ideally were recommended when the ejection fraction was less than 40. So ARNI is now recommended as the drug of first choice over ACE inhibitors or ARBs in patients with heart failure. Why first choice? Because they block 2 pathways. They block the renin-angiotensin pathway and it augments the dilatory vasoactive peptide pathway by inhibiting the neprilysin inhibitors. They work very, very fast. Within the first 2 to 4 weeks, we start seeing the mortality benefit and the rehospitalization benefit. It's safe, effective, and it also lowers the blood pressure to some extent, so they can be very useful in hypertensive heart failure patients. The guideline there has been a paradigm shift. There was this vertical approach previously. There was the emphasis on starting one drug, then add another drug after some time. First optimize or up-titrate the dosages of the first drug. If needed, add the second drug. Whereas the shift now is that you start all the drugs together and get all the drugs to the targeted dosage so that there is no delay, because essentially time is survival. With regards to stages of heart failure, if we see the stage A, which is essentially the presence of risk factors, it really more focus is on the management of risk factors. The stage 2 is where there is an anatomical substrate, or stage B, sorry, there is an anatomical substrate for heart failure, but no clinical symptoms yet. If the patients there, the role of starting ARNIs and beta blockers is prime. When the patient becomes symptomatic in stage C heart failures, then all these 4 drugs should be on board. If the patient remains refractory, ancillary therapies like hydralazine can be tried, or the patient has a broad QRS on ECG more than 150 milliseconds, CRTD, may be tried. If still the patient remains refractory, then the patient can be referred for circulatory support like LV assist devices or cardiac transplantation. So as we see the benefits of initiating all these 4 pillars, 4 medicines early and getting the dose up titrated fast, within 2 to 4 weeks we see a reduction in mortality, we see a reduction in hospitalization and rehospitalization within the first month itself, then improvement in health status well-being at 1 to 8 weeks, and as Dr. Vishal was trying to show, the heart failure with improved ejection fraction. Many of these drugs leads to improved ejection fraction as well, which we start seeing by end of 12 weeks. So 3 months we might see LVF improve. પહેલા એવું કહેવાતું કે એકવાર ડાઉન થઈ ગયું LV, then it doesn't improve beyond the acute stage, but these wonderful drugs do improve the ejection fraction. So 4 drugs blocking 5 pathways leads to 6 additional years of survival. That's a significant major benefit that we get. One recently published in the ESC Congress of Madrid recently, one trial which studied about 450 patients. Out of that, 100 were discharged on the 4 drugs in targeted doses, and 350 patients were discharged on lower dose or suboptimal dosages. If we see the difference in the right corner down, the patients that were targeted were discharged with the highest or the optimum dosages, the mortality in those patients was 10% compared to 23% in the patients with suboptimal dosages. So we should, as somebody was trying, target LDL to less than 70 or 50. We should also target to optimize the dosages as high as possible. The Kaplan-Meier curve here reflects the decrease or the survival benefit. If you see on this x-axis, the number is the time, and the y-axis is the survival. See how early the curve starts separating, the red curve showing the beneficial effects or improved survival compared to the blue curve. I would like to have a look on the last green bar only on the left side, that in hospital initiation of all these 4. Suppose the patient is hospitalized for heart failure with an heart failure episode, we should target to start all these 4 medicines in hospital, because then the patients are more likely to tolerate, we can manage the side effects, the labs done in the hospital. They are more likely to purchase these medicines before discharge. They are more likely to remain compliant and take these medicines. They are more likely to feel better, more likely to be at home with regards to preventing hospitalization, and likely to live longer. If we see the mortality journey of the heart failure patients, the first in hospital episode statistically in Western countries or worldwide data shows a 6% in hospital mortality. Then the patient gets discharged, and the first vulnerable phase or the susceptible phase of the first 3 months, where the mortality or rehospitalization rates are ranging from 10 to 30%. And then there is this chronic phase where the 5-year average mean survival is about 50%. So if we see here, time is prognosis. We used to say time is money and time is muscle, time is prognosis in heart failure. Time to treatment initiation is a modifiable risk factor. We can all modify this time, we can reduce this time for optimum patient benefit. Previously, in the previous generations, the technological adaptation was pretty slow for an of course the population was also low, but for the 50 million users for an airplane took 68 years. If you see this, for Facebook or Twitter, 50 million users have been in 2 years. As clinicians or as a elite community, still it takes about 10 to 20 years for us to incorporate these guidelines into our day-to-day practice. These molecules all have been there for more than 10 plus years. But how many of us are targeting or focusing all these 4 molecules in the right dosages at in all our patients? Finally, to the last slide of my talk, that heart failure runs a malignant course, and all therapies should be escalated to target doses unless side effect profile precludes their use. The 4 foundational drugs should be used for all patients in optimal dosages for incremental benefit and improved survival. We should get over the physician inertia ourselves, and then we should be able to motivate the patient to take these medicines for lifelong, for them to live longer, and developing healthcare infrastructure like developing heart failure clinics, a dedicated clinician for that, a dedicated nurse for that, digital consultations, teleconsultations, and repeated reminders should be given to patients for them to abide by the treatment, and that will make them live longer and better. I think my talk is very close to lunch, so I have finished a couple of minutes earlier. Thank you all for your kind attention.